Now it's my privilege to introduce today's first session, Challenges and Opportunities in Xenotransplantation. Xenotransplantation, the transplantation of organs or tissues from one species to another, represents one of the most exciting and rapidly advancing frontiers in transplantation science. It offers hope to address the critical shortage of donor organs and to improve the lives of countless patients waiting for a transplant. At the same time, it raises important scientific, ethical, and practical challenges that must be carefully considered as this field moves forward. We are fortunate to have with us today three outstanding leaders joining remotely who will bring unique perspectives on this evolving area. Dr. Elisa Gordon is a professor in the Department of Surgery and Center for Biomedical Ethics and Society at Vanderbilt University Medical Center, where she also serves as Associate Director of the Vanderbilt Center for Transplant Science. Trained as a medical anthropologist and in clinical medical ethics, Dr. Gordon's research focuses on developing and evaluating organizational, educational, and digital health interventions to improve informed consent, strengthen treatment decision-making, and reduce health disparities among kidney transplant candidates and living donors. She also serves as the co-chair of the Kidney Health Initiative's project to create educational resources about xenotransplant clinical trials. The Kidney Health Initiative was founded in 2012 as a partnership between the American Society of Nephrology and the U.S. Food and Drug Administration. Dr. Mike Curtis, who serves as the President and Chief Executive Officer of eGenesis and brings over 30 years of scientific and leadership experience in biopharmaceutical drug development across multiple therapeutic areas. Before joining eGenesis, he served as CEO, President, and Head of Research and Development at Cadence Therapeutics and was an entrepreneur in residence at Atlas Venture, helping launch several companies including Delinea and Q32 Bio. Dr. Curtis has also led the development of multiple products from discovery through late-stage clinical trials. And finally, Dr. Leigh Peterson, Executive Vice President of Product Development and Xenotransplantation at United Therapeutics, where she oversees all preclinical and clinical development efforts. Dr. Peterson joined United Therapeutics in 2008 and has held key leadership roles in advancing the company's xenotransplantation pipeline. To begin our session, please turn your attention back to the screens as we welcome Dr. Gordon, who will address the ethical challenges surrounding this emerging field and examining opportunities to develop a framework that ensures safe and responsible progress. Dr. Gordon.
Good morning, everyone. It's so nice to be a part of this. I would like to thank the AAKP for inviting me to present today. I'm delighted to be a part of the 50th Annual National Patient Meeting. There are a number of ethical issues that xenotransplantation raises in general. Just to give you an example, there are questions about the moral status of using animals to treat people, or questions about organ allocation of kidneys should xenotransplantation become mainstream. And these are important issues. We're just not yet there at the point of providing xenotransplantation in routine clinical practice, as the field has just started doing research on humans. And it's the first in human research context that raises other unique issues that need to be examined. So for the purposes of my talk, I will be focusing on ethical issues in xenotransplant research and clinical trials. These are my disclosures. I do want to acknowledge the NIH for funding a grant ethical and policy guidelines that we helped with updating in xenotransplantation. That study is now over, but not listed here, but I do refer to that project. So xenotransplantation of organs from non-human animals into human recipients is what we're discussing today. It's got a lot of promise for potentially alleviating the organ shortage. And transplant programs may seem initiate first-in-human pig kidney xenotransplant clinical trials. And these trials raise numerous ethical issues. There have been 2 trials that have been registered, and I'm going to touch on a few ethical issues. For example, participant eligibility criteria, informed consent, voluntariness, and monitoring, and first-time scientific validity. All right, but before delving into ethical issues, I'd like to be sure that we're on the same page about what clinical trials are and what to do. All right, so what is a phase 1 clinical trial is a research study, and the purpose of the study is to find out whether the pig would be safe for human recipients and if the pig works when transplanted into a human. Now, phase 1 trials conducted for the first time in humans, which raises the stakes in protecting and prioritizing patient safety. Patient safety is number 1. I do want to point out that the FDA, Food and Drug Administration, plays an important role in clinical trials, and that's because they regulate xenotransplantation as a biological product. They can approve xenotransplant trials for starting. They would approve xenotransplants outside of a trial for patients under the expanded access or compassionate use program, as has been done several times. And the FDA also decides if there is enough safety or efficacy evidence from the trials to approve xenotransplantation for use in routine clinical care. The issue of eligibility to participate in xenotransplant clinical trials. All right, so the issue of eligibility is difficult to answer in terms of who would be eligible to participate in a trial and has been the subject of much debate. It raises ethical issues of justice and equity. And here are some questions to consider. For example, should trials be restricted to patients who are currently on the kidney transplant wait list? Should patients who are eligible for a human kidney not be considered for trial participation? Should any social or psychological criteria be used to determine eligibility? Now, with regard to first of these, one rationale is that we want to be sure that those who are qualified for an allotransplant and able to withstand the allotransplant surgery are able to undergo xenotransplant. And with regard to the second point, one rationale is that waitlisted patients may soon get an allotransplant, and trial investigators may prefer for patients who may have not yet traditionally had access to the wait list to now have that opportunity to get a xenotransplant. All right, so let's take a deeper dive into what these questions mean. So is it ethical to include waitlisted patients only? So the rationale being that patients ineligible for a human kidney would be too frail to survive a xenotransplant operation or too immunocompromised. But this reinforces inequities that just are pervasive. For example, the structural and systemic barriers that contribute to disparities in patients' access to the kidney transplant waiting list. And we all know that fewer patients who identify as Black or Hispanic or other minoritized groups, or people who are older or from rural areas or who have lower socioeconomic status, are less likely to be referred to transplantation, complete evaluation and testing, or get waitlisted. So that raises the concern about whether clinical factors should supersede equity factors in this context. Alternatively, to counteract this potential inequity, what if patients were ineligible if they were more likely to reject a human organ, or that is, be less clinically eligible for a human organ? For example, such potential participants might be kidney candidates who are highly sensitized and therefore they will be waiting a long time for a human organ and might die while waiting as a result. And the concern is that trials should not recruit participants who have too many comorbidities in order to enable subjects to potentially benefit from xenotransplantation. So We just need to remember that safety is the number one priority in our clinical trials as they proceed. Who is actually eligible to participate in a trial ultimately depends on the trial and the sponsor. And there are two sponsors that have genetically modified pigs ready for research in potential kidney recipients, and United Therapeutics sponsor has FDA approval to conduct a trial at New York University Langone. They report many criteria, and you can go online and see a bunch of these criteria. I just picked out a couple of these to point out to everyone what's online here. Patients with kidney failure who are ineligible for an allotransplant for medical reasons, people who are aged 55 to 70 years, or people who are waitlisted but are more likely to die or not receive a transplant within 5 years. The eGenesis sponsor has FDA approval for the FDA compassionate use study for 3 transplants. So I'm going to shift gears and focus a bit on informed consent to participate in xenotransplant trials. All right. There are a number of elements of the informed consent process, and I'd like to highlight the unique features of informed consent in the context of xenotransplantation. So just to point these out, there are preconditions of being competent, expressing voluntariness, informational elements of disclosure of information and then comprehension of that information, and then consent elements of being able to provide a voluntary decision and authorization to proceed. So I'll focus on a couple of these. All right. The xenotransplant trials present ethical challenges for obtaining participants' informed consent. Foremost, there's very little data on the xenotransplant recipient and graft outcomes available because this is the first time it's being done in a human. We know a little bit from the compassionate use context, but that's not really a clinical trial context. And still, there's just been very few of those that have been done. Very little is known about the risks and benefits to trial participants. In addition, potential trial participants may have ineffective or non-existent alternative treatment options. Therefore, information disclosure is particularly difficult because so little is known about how humans experience xenotransplants to inform potential participants. So potential participants will have to weigh a lot of these unknowns before deciding whether or not to participate, which can make it hard to give an informed decision. And several factors may compromise voluntariness to participate in research, including, for example, limited alternative options, perceived or actual external or internal pressures to participate, undue influence, prohibiting withdrawal from participation. And I can go over a few of these briefly in terms of how they may apply in the xenotransplant trial context. So in the context of limited alternative options, some patients may perceive having that no alternative option for life-sustaining treatment may be a form of pressure. And that's because participation in trials would most likely be offered to patients with a high likelihood of perhaps dying on the wait list or not being able to receive a transplant. And patients may perceive that having no option for life-sustaining treatment as a form of undue pressure. With limited care options, patients may feel that their only option is to enroll in a trial. And results from our research, in which we interviewed and surveyed kidney transplant candidates, support this concern. In particular, patients in our study were more likely to participate in trials if they were ineligible for a human kidney and if their health status declined. In addition, patients may feel some pressure to participate from family or caregivers, and they may feel pressure from healthcare providers or the transplant team who may want to be amongst the first to engage in these trials. So this raises a question, and it would be wonderful to hear everyone's perspective on this. How should the transplant team engage patients in an opening conversation about the prospect of participating in a xenotransplant trial without exerting any pressure? And, another concern is about withdrawing and monitoring. And so voluntariness in research involves the right to withdraw at any time. And because of the unknown risks of graft rejection and zoonotic infection, lifelong monitoring has been proposed as a mandatory part of trial participation, and it's very controversial. And that's even if the xenograft is later removed. In our interview study, most participants, 21 out of 28, would accept being monitored for as long as the research team would feel necessary. But our participants were less receptive if monitoring included close contacts, like people who they live with, for example, which was perceived as interference and burdening their loved ones. This just raises a couple more questions. Should participants be able to withdraw from lifelong or long-term monitoring in trials? And should a participant's right to withdraw supersede monitoring of public health risks regarding potential transmission of zoonoses? So in the interest of time, I'm going to wrap this up. A number of ethical issues abound in first-in-human pig kidney xenotransplant clinical trials. I just touched on a few here. And stakeholders need to be mindful of the limitations of the informed consent process and be transparent about these concerns with patients and potential participants. There needs to be safeguards that are established to protect patients from experienced potential undue pressure to participate in trials, ensuring that transplant teams and potential participants are aware of these possible threats. Future research should assess patients' actual decision-making and the adequacy of the comprehension upon trial initiation. Moreover, trial investigators should refine the eligibility criteria and the informed consent process based on actual recruitment experiences via a continuous quality improvement feedback loop or learning model. I do want to point out that my team and I developed a number of resources on xenotransplant trials. I'll point out one. We developed a decision aid for patients who may be considering participating in a xeno trial. All of these resources are available for free access at the Hastings Center for Bioethics website, which was listed in the prior slide. Anyway, I would like to thank you all so very much for your time and for listening. Thank you.
Thank you very much, Dr. Gordon, for sharing your work with us and addressing this very important issue. And next, we're pleased to welcome Dr. Curtis as he shares insights on the pioneering work being carried out by eGenesis in this space. Dr. Curtis?
Great. Thank you, and big thanks to AAKP for their support over the years. We're really pleased to be involved with this patient community, and we think that's an incredibly important piece to the progress that we've experienced to date. So I'd like to introduce you to Mr. Tim Andrews from Dover, New Hampshire. On June 11th of this year, Mr. Andrews had the honor of throwing the ceremonial first pitch at the Red Sox game. That's Tim there throwing the ball. And just 130 days prior to this pitch, Tim was confined to a wheelchair, battling end-stage kidney disease, enduring dialysis 4 times a week. And when you speak to him, he felt like he might not even ever go to a Red Sox game again, let alone throw the first pitch. And so 138 days prior to this pitch, Tim received an eGenesis eGen2784 transgenic porcine kidney. I'm very pleased to report that Tim is now 252 days post-transplant, dialysis-free, and continuing to do well. So while Tim was busily throwing out the first pitch, across town at Mass General, Mr. Bill Stewart was getting ready to receive the second eGen27, or actually the third eGen2784 kidney transplant. So 3 days after Mr. Andrews threw the pitch on June 14th, Mr. Stewart received the eGen2784 kidney. And now Mr. Stewart is also doing well post-transplant. He's now 112 days post-transplant. And we're just thrilled with the progress so far. So to make all of this happen, about, let's have a hard time on this one. March 16th of 2024, about 452 days before Mr. Stewart and 315 days before Mr. Andrews, Mr. Rick Slayman made history as the first person ever to receive a transgenic porcine kidney. It's really hard to overstate how important Rick's contribution was to this field. Rick really went into the unknown. And I'll take you through some primate data and some rationale that we had to even propose this to him, but he still had to go first, right? And when you think about Mr. Andrews and Mr. Stewart, they had the advantage to seeing how Rick did in the first 51 days. So pictured with Rick is the whole some of the transplant team from Mass General, Dr. Elias, Dr. Kawai, and Dr. Riella. The partnership here between eGenesis, Mass General, and the patient community is paramount to making any of this happen, right? So we are incredibly grateful to Rick, his family, and the team at Mass General for allowing this to happen. Now, unfortunately, in addition to end-stage kidney disease, Rick also suffered cardiovascular disease, and he passed away on day 51, following an arrhythmia. But again, his courage, it's really hard to overstate just how important this first step was. And then earlier this year, Mr. Andrews and Mr. Stewart were fortunate enough to be at MGH at the same time. So this is showing a picture of them together. We're currently planning on another transplant in the series before the end of the year. So Mr. Andrews and Mr. Stewart are the first two patients to participate as part of our 3-patient expanded access trial that was approved by the FDA last December. And what was incredibly encouraging about this trial is it looks very much like the trial we recently had approved as a registration study. So in this trial, we're looking at patients 50 to 70 on dialysis for at least 6 months. Importantly, these are older patients, they're type O blood, they have a very low probability of receiving a human kidney within the next 5 years. And unfortunately for these patients, the longer you spend on dialysis, the more your health deteriorates, and the potential for you getting delisted because you're not healthy enough for a transplant becomes real. And these older patients face a 50% mortality rate, at 5 years, right? Which is similar to some oncology indications, or actually worse than many oncology indications, right? So the risk of mortality for these folks is real. When you talk to Mr. Andrews or Mr. Stewart, that is on their mind as they sit in the dialysis clinic. So we were thrilled that the agency allowed us to go into these patients that were relatively healthy and really could benefit, from transplant. What we really wanted to do is move away from patients, at least initially, like Mr. Slayman, who had comorbidities that put him at greater risk of passing away from things even other than end-stage kidney disease. The intention of this study, was to produce some pilot data. And again, we're really happy to say that Mr. Stewart and Mr. Andrews are doing well. We're learning a ton from these first two patients. The immunosuppression that we're using in this trial is similar to what's used in allo. So we're using allo transplant preconditioning, tacrolimus and MMF. But importantly, we're including a investigational drug, tegoprubart, which is what we refer to as an anti-CD154 T-cell co-stimulation blocker. So what this does is it reduces the ability of the T cells to respond to the graft. And we've seen in monkeys that we get much better outcomes if we use this investigational drug. As I mentioned, we intend to enroll one more patient as part of this study before the end of the year. Patients are currently in screening. So before we proposed the first study with Mr. Slayman back in March of 24, we had completed a series of non-human primate transplants, which were published in Nature in the fall of 2023. And in this series of transplants, and this is what really encouraged us to move to the clinic, we presented this at a National Kidney Foundation meeting in the fall of 23. I think there was about 20 patients in attendance. And the question was, would you participate in the xenotransplant trial? And what was encouraging about this data set is we had 7 animals out over a year post-transplant, and we had 1 animal over 2 years. Right, so this set the foundational data to suggest to us that there's the potential, right, that these organs could function for at least a year, maybe 2 years. Obviously, our long-term goal is to have as long as possible, 10, 15 years, and ultimately without the need for immunosuppression. So this was the encouraging data to say, okay, we should move into the clinic, and to do it in a way that's consistent with patients, the patient journey, and older patients in dialysis, like Mr. Slayman, Mr. Andrews, and Mr. Stewart. In February of this year, we published the results from Mr. Slayman's transplant, and you can see here creatinine in the blue dots, really well controlled. If you look at his pre-transplant creatinines, it was over 10. Within the first week, we saw a nice resolution of his creatinine to normal levels. And then even through the whole course of the 51 days, good kidney function, good urine output. And for those on dialysis, they all realize this, many people don't, is that people on chronic dialysis don't urinate on their own. And so this was the first urine that Mr. Slayman had made on his own in about 4 years. So he was, incredibly excited. And this led us to the trial that we submitted to the FDA in July. So a combination of the primate data, Mr. Slayman's experience, and then the experience we had at the time with Mr. Andrews and Mr. Stewart led to the submission of what we refer to really as a phaseless trial. So it's phase 1, 2, 3 in 30 patients. So this is the design that we got approval from the FDA for in August. And this is, again, a total of 33 patients. And what we were very encouraged by is it looks a lot like our expanded access trial, right? Age criteria are the same, 50 to 70. We've gone to shorter amounts of time on dialysis. So instead of being at least 6 months, now it's at least 3 months. Again, similar. We're looking for patients who have a low likelihood, based on statistics and experience, of getting a human graft. All these patients are listed for human transplant. The problem is a lot of these folks spend years and years on the transplant wait list, never get a transplant, continue to decline in health, and eventually get delisted, right? So, and what FDA has agreed to here is a 50% chance of allotransplant in the next 5 years. When you actually look at the existing transplant waiting list, this eligibility criteria is about 2/3 of the current, depending on which geography and all, but roughly about 2/3 of the current transplant waiting list. Endpoint in this trial is a 6-month post-transplant graft function. We were thrilled that Mr. Andrews has already surpassed that. He's almost 9 months post-transplant. Of course, we want to go as long as possible, but what was really encouraging is that the FDA, and we've been working with the FDA now for probably about 8 years, realizes the unmet need in select patients with end-stage kidney disease, and where 6 months, 12 months, 24 months is clinically meaningful. Again, if you just talk about Mr. Andrews' case specifically, he never thought he'd go fishing again, right? And now he's been able to go fishing again, right? So there are real quality of life improvements getting patients off dialysis into transplant. And the second patient in history to receive an eGen 2784 kidney is already past 8 months, right? And so we're really encouraged as we move into this registration trial. Immunosuppression that we're using in this trial is the same as we were using in the expanded access. Really no changes there. The way the trial is designed is a part 1 study where we'll enroll 3 more patients with a 12-week period between patients. And then at the end of that period, which we expect to be maybe the second half to end of the third quarter of next year, we would then launch into the 30-patient expansion study, which would include 30 patients with no sentinel period, allowing us to do concurrent enrollment. We currently have a donor production that easily supports this study. And so we're going to start these studies with a focus of patients on the transplant wait list. And again, these older patients, harder to transplant or hard to find a match for, typically type O blood is what we're focused on. And the initial goal is to at least get, past 12 months post-transplant. And again, based on the monkey data, we expect we can go longer, but only time will tell, and only can we really demonstrate that in patients. But when we think about destination therapy, we really frame that as a 3-year post-transplant outcome. With the potential at the end of 3 years, you could potentially get a second porcine kidney, or is that 3-year window sufficient? Because one of the things that we've been speaking to UNOS about is to not lose your spot in line, right? So the typical wait time, like for instance, for Mr. Andrews, he had about a 7-year wait time at Mass General for an allo kidney transplant. If he spends a few years on a porcine kidney transplant, doesn't lose his spot in line, he still has a potential to get a human graft. And we've done, I think Dr. Gordon brought up the idea of, does the xenotransplant negatively affect the potential human transplant? We've done a bunch of work in the monkeys to show that we don't believe so, that even if you did end up rejecting a porcine kidney, you still should be able to get a human kidney and have a good outcome, right? So what's really important to us is patients that are on the transplant waiting list that join the study don't lose their spot and don't lose their wait time in the human allo transplant wait list. But of course, we all realize that the transplant wait list is a small fraction of the number of patients that are suffering from end-stage kidney disease. We have well over 450,000 patients on chronic dialysis. And also, as Dr. Gordon mentioned, most of those patients don't get listed for transplant, but we know all of those patients could benefit from a transplant. And so the real opportunity here is not only to eliminate the transplant wait list, but really to move into this much larger population of patients on chronic dialysis. And then, of course, we have the group in the middle, who are patients who've been fortunate enough to receive a human graft, But at some point along the line, those grafts will likely fail, and then they either need a second graft or they'll need to return to dialysis. So xeno after allo is another thing that we've been exploring in the monkey. And so far, there seems to be no reason why you couldn't receive a porcine kidney after a human graft failed. So what's enabling this whole thing to happen is our ESA 1784 porcine donor. It is the most genetically advanced mammal in the world. And when we approach genetic engineering, and really, if we take a wild-type porcine kidney and try to transplant it into a monkey or into a person, it will get rejected within minutes to hours and be completely non-functional. So the field has spent the past 30, 40 years trying to figure out how do we make porcine donors more compatible with human recipients. And the way we approach this is really three different classes of genetic modifications of the pig. The first is the inactivation of retroviruses. And in the 90s, it was discovered that all pigs carry retroviruses. These retroviruses pose a health risk to patients. And this is part of the reason for this lifetime monitoring is we're not really sure what happens to these retroviruses when you put them into a person and put that person on immunosuppression. So our approach is to inactivate all copies of the retrovirus in the genome. And this is something that we've been talking about with the FDA again for probably the past 5 years. And so each pig carries 60 to 70 copies of these retroviruses embedded in the genome. We use CRISPR-Cas9 to inactivate all copies. So all of our donors are 100% retrovirally inactivated. The next class of edits is to eliminate the incompatibilities between pigs and humans that lead to hyperacute rejection. These are all related to carbohydrates or sugar differences between pigs and humans. By inactivating 3 more genes, we get rid of that chance for hyperacute rejection. And what's really encouraging is all of the human transplants that have been done over the past few years, there has been no signs of hyperacute rejection, which is amazing for the field. No one knew that was true until about 2-3 years ago. And then the last class of edits is the addition of human regulatory transgenes. In 1784, we're including 7 regulatory human transgenes. And the idea here is we add human genes to control things like innate and adaptive immunity, coagulation compatibility, and complement activation. So by adding these human genes, we essentially protect the graft from a human immune response or human compatibility. One of the things that can lead to an early graft failure is something called thrombotic microangiopathy, where you get these small clots in the graft, in the blood vessels of the graft, which makes the graft ineffective. By adding, for instance, human coagulation regulatory proteins, we can avoid the formation of that TMA and get good graft function. And what's amazing so far, right, is we've now treated Mr. Slayman, Mr. Andrews, and Mr. Stewart, multiple biopsies. We're not seeing these effects. We're not seeing B-cell, T-cell activation. We're not seeing rejection. We're not seeing TMA. When we get the immunosuppression correct, it's been amazing. And the other part that I'll just mention is when we do see a rejection event, and they have happened, is that we believe that these transgenes are protecting the graft in a way that allows us to intervene. So it allows us to either increase the suppression, change the suppression, essentially saving the graft and putting the graft back on the good track. We saw this with Mr. Slayman. We've seen it with Mr. Andrews. We see it with Mr. Stewart. There's always things that happen, and patients have had a transplant understand this. Once in a while, you'll get an infection, and then we'll have to adjust the immunosuppression. Well, when we do that, we jeopardize the long-term function of the graft. So far, when we've had to do that, we've been able to manage through that, and this is why Mr. Andrews is 252 days post-transplant. So the other thing I'll mention about our animal donor is that the organs, because we chose the Yucatan mini pig, are correctly sized. So these animals are 150 kilos fully grown, 70 pounds. They produce organs that are correctly sized for people, so we don't need to introduce any additional genetic edits to control organ size. Now we're using these organs to run 3 different programs. Our primary program is our kidney transplant program. As I mentioned, we'll do another, knock wood, another transplant before the end of the year, and then launch that 33-patient trial early next year. And then we're also developing a product for supporting patients that are in end-stage liver failure. We're doing this through what we call extracorporeal liver cross circulation, where we circulate a patient's blood through a porcine liver that sits on a pump. We're partnered with our friends at Organox and now Terumo. That IND was approved by the FDA in April, and we're imminently waiting for first patient in that trial. And then the last one, but certainly not least, which is an incredibly exciting program in heart transplant to treat patients in end-stage heart failure. We now have a baboon that has achieved over 2 years of post-transplant function with an orthotopic transplant. We'll do some additional primate work this year and expect to start a study next year. So, where we started, 7, 8 years ago and where we are now is just we're pinching ourselves, how far we've come. And I think for patients, this idea of, Xeno is the future and always will be, I think we're all now living in the future. I think we will be able to bring these products to patients within the next, 3 to 4 years. So again, huge gratitude to AAKP, patients. It really takes all of us to bring this technology into reality.
Thank you, Dr. Curtis, for your thoughtful insights and for the outstanding work that eGenesis is doing in this field. We at AAKP have deeply valued the opportunity to partner with you and your team over the recent years, and we look forward to continuing this important collaboration as we work together to expand the options and hope for patients. Finally, we're excited to welcome Dr. Peterson, who will dive into United Therapeutics' commitment to this space and highlight their recent breakthroughs that are bringing this innovation solution closer to reality. Dr. Peterson, we're delighted to have you with us, and I turn the program over to you.
Thank you very much. I'm Leigh Peterson. I lead product development and xenotransplantation at United Therapeutics, and I'm really happy to present to you where we are in xenotransplantation, and thanks very much for the organizers for inviting me. As everyone here at the meeting knows, organ transplantation is the only life-saving intervention for many patients with end-stage organ failure. And unfortunately, there's an extreme shortage of organ donors relative to those hundreds of thousands of patients who need one, and the gap continues to grow. So xenotransplantation is one solution to the organ shortage. And as defined earlier, it's the implantation of live cells, tissues, or organs from a non-human animal source to a human recipient. And again, it's different from allotransplantation, where the source is from other humans in that case. And unlike with allotransplantation, these organs could be of uniform quality. The pigs are raised in a designated pathogen-free facility to reduce the risk of transmitted infectious diseases, and the waiting period could be significantly reduced. Why are pigs genetically engineered, and why are they a suitable organ source? Well, pig organs, and especially the kidneys and hearts, are similar in size, structure, and function to those of humans. They're readily available and sustainable. Pigs have large litters with only a 4-month gestation period, and their organs reach human adult size in 6 to 14 months based on their genetics. And hundreds of millions of pigs are used annually for human consumption, so there should be little ethical objection to using pig organs to cure human disease. So again, why do they need to be genetically edited? And Dr. Curtis touched on this a bit, but the main reason is that normal or wild-type pig organs will undergo hyperacute or immediate rejection right after transplant. And the reason is that humans have a large amount of anti-pig antibodies, and alpha-gal is really the most abundant. The gene that synthesizes alpha-gal isn't functional in humans, but because we're exposed to it through our diet and intestinal microbiome, we develop these antibodies, anti-alpha-gal antibodies. And what happens is that they recognize alpha-gal in the vessels of the graft, which leads to this whole cascade of events that causes hemorrhage, clotting, and ultimately destroys the graft. But if the gene that synthesizes alpha-gal is inactivated or knocked out, as we call it, and the pig xenograft doesn't contain alpha-gal, then the chance of this immediate hyperacute rejection is significantly reduced. In 2002, it's hard to believe it's been that long, Revivicor, which is now a part of United Therapeutics, reported the world's first pigs with a knockout of the gene required to synthesize alpha-gal. And in 2020, this was the very first animal to be approved by US FDA for use for both food and human therapeutics. And it's called gal safe because it's safe for people to eat who have alpha-gal syndrome, which is a red meat allergy. One of our xenokidney programs uses this single knockout gal-safe pig to generate our euthymo-kidney. And what this is a composite graft made up of both thymus tissue and the kidney. And so it's generated by removing the thymus of a pig and implanting pieces of that thymus under the kidney capsule and letting it mature for about 6 to 8 weeks. And then at that point, the composite graft can be transplanted into a recipient. And our intention here is that the pig thymus will actually make the human immune system more tolerant of the pig kidney and reduce the likelihood of rejection. And I mean, this is really the holy grail. If we can achieve tolerance of these organs, we could reduce or possibly even eliminate the long-term immunosuppression that's currently required even for human-to-human transplants. And this would be amazing because those medications can be associated with serious side effects. So since producing the gal-safe pig, we continue to do research over the next 2 decades with our partners to determine the other genes that might be important to either inactivate or insert into the pig genome to enhance compatibility. And this led to the generation of our 10-gene pig. This is essentially similar to what Mike Curtis has described for the eGenesis pig. We have the knockout of the 3 major carbohydrate antigens. And then we also have a knockout, in our case, of the growth hormone receptor gene, because our pigs are normal-sized pigs. They're not mini pigs. And this allows the organs to stay human size. And then additionally, we inserted 6 human transgenes to make the organs more compatible with the human, including 2 genes that inhibit a specific component of the immune system called complement, and 2 that regulate coagulation or clotting, and then also to reduce inflammation. And then one other thing I just wanted to touch on, you also heard that from Dr. Curtis that their pig has an additional 59 gene edits to inactivate PERV elements. And for our pigs, we actually, it's not necessary to make those edits because our pigs are naturally free of PERV-C, which is a subtype of the virus that seems to be required for productive PERV infection of human cells. So we're often asked why we are developing both the UKidney and the euthymo-kidney. And it's because we believe that there's advantages to both, and each has slightly different mechanisms to reduce the chance of rejection. And we've seen good survival and function of both of these organs in preclinical studies, and that includes monkey studies as well as human decedent studies. And so the 10 gene, just to summarize quickly, the 10 gene edits act to modulate multiple arms of the immune system, as I discussed, through each of these edits. But the single genetic modification of the gal-safe thymokidney, which is the alpha-gal knockout, or gene that synthesizes alpha-gal, addresses the major cause of antibody-mediated rejection. But through the selection of tolerant recipient T cells, the included thymus tissue is also intended to modulate multiple arms of the immune system. For example, B cells for antibody production, NK cells, macrophages, and neutrophils that all need T cell help to act against the xenograft. And our goal is to obtain FDA approval of multiple xeno products, just so we have different options available for patients and enhance the available supply. And UT is actually known for taking multiple shots on goal, so this is consistent. Again, we have multiple xenotransplantation programs, including the UKidney and the UHeart, using our 10-gene pig as source, as well as what I just earlier described as our euthymo-kidney program. And we've received FDA clearance of 2 INDs to conduct multi-center clinical studies in up to 50 patients each with both the UKidney and the euthymo-kidney. And our first IND clearance, we were delighted to receive was back in January of 2025. And I'll give you details of those in just a few minutes. So this is just a snapshot of the work that UT's done with our academic partners using our organs. Starting in 2021, University of Alabama, University of Maryland, and NYU have transplanted our 10-gene kidney and heart, as well as our Gal-safe thymokidney, into 8 human decedents and 4 living humans under EINDs, compassionate use INDs. And most recently, NYU transplanted our 10-gene edited kidney into Ms. Tawana Looney, which she had for about 4.5 months. Just to summarize the findings of these cases, now again, I'm focusing on the human cases and not the monkeys here. And so these guys, but most of this is true for our monkey cases, they didn't immediately reject, as is the case with both the hit kidney and the heart functioned and were life supporting. And we were actually able to use immunosuppression that's currently used for allogeneic kidney transplantation. And it was effective, and as long as the therapeutic blood levels were maintained, and it was effective in even reversing rejection events in a couple of cases. We didn't see any infections of the recipients that related to the xeno organs. And our most recent patient, again, Ms. Tawana Looney, was able to leave the hospital, discontinue dialysis for over 4 months, and reported a significant improvement in the quality of life during that time. Okay, and so now I'm going to talk about the challenges, which is part of the title of my talk. Many of the challenges are similar to those for the allotransplantation. Required that there's a tissue match between the source, the donor, and the recipient. And like different humans, different pig cells have molecules that the recipient's immune system may react to as foreign. But it's important to note that if someone has difficulty finding a tissue match with a human donor, so they're hypersensitized, it doesn't necessarily mean that they won't have a match with the pig organ. And again, also, which is true for allotransplantation, it's extremely important that there's a very, very careful balance of adequate immunosuppression to prevent rejection, but not so much that infections occur. And just to give a very short summary of our case, our most recent case, again, she had our xenokidney, 10-gene xenokidney, for about 4.5 months. And she also had several unrelated infections, and that actually required a decrease in immunosuppression, even below the amount required to prevent rejection of a human kidney. She's a pioneer. Remember, at the time, she was the first and only person to in the world to have a xenokidney longer than 3 months. And her medical team was conservative in mitigating the consequences of her infections. Some just to the next bullet, there's a few challenges that are unique to xenotransplantation. This is just a couple, and we will continue to discover more and more as these studies. Some of the challenges that we've discovered during our EIND cases is that, as you all know, after surgery or other treatments, recipients may need to receive human blood products such as IVIG or plasma. And it's important that to only use these human products that have been tested beforehand and shown to have a low level of anti-pig antibodies. Previous slide said that for the most part, we've seen that the pig kidneys function normally, but there's some incompatibilities that might require supplements like EPO, giving human EPO. All right. Here are the titles of our first, the 2 clinical studies that have been cleared by FDA. And just to go over these, we worked really carefully with FDA last year to design this phaseless study. And again, this is also a seamless registrational study. It includes an initial cohort of 6 patients, and after each receipt reaches at least 12 weeks post-transplant, the data will be analyzed by the DMC and the FDA, and a decision regarding cohort expansion up to 50 patients will be made. And each patient follows 2 parts, 6-month follow-up period, after which all of the study endpoints are assessed, which includes survival rate and time, and of both patients and the xeno organ function, quality of life, and of course, safety is of the utmost importance, including AEs, SAEs, and incidents of infections. And then Part B consists of overall safety and survival for the lifetime of the participant. And this is the last one, which is this also addresses some of the things that Dr. Gordon brought up. In each of these studies, there will be 2 groups of participants enrolled. They have end-stage kidney disease on dialysis, and group 1 are participants deemed ineligible for conventional allogeneic transplant due to medical reasons. And group 2 participants may be on the transplant wait list, but are more likely to die or go untransplanted within 5 years than receive an organ. And again, the reason for these requirements is because, as we all know, xenotransplantation is still investigational. We prefer that the patient receive an allotransplant from another human if they have the opportunity. With that, I'll say thanks very, very much for asking me to speak at this really important meeting. And most of all, we're extremely grateful for the patients and their families who volunteer to be a part of this research. Thanks a lot.
Thank you very much. Before I let all of you go, and thank you very much, all 3 of you, for your presentation. Before I let you go, I just want to ask each of you one question, the same question, 2 parts. I'll start with Dr. Peterson. For each of you, what do you see as the single most important opportunity and the single most important challenge in bringing xenotransplantation safely and effectively to patients?
I get to go first, huh? So the single most important, obviously the single most important challenge is to really show that the safety of these organs. I mean, as I actually just returned from the International Xenotransplant meeting in Geneva, and we talked about allotransplantation. People have 10, 20, years of kidney survival, and eventually we hope to get to that in a very extremely safe way. And also, informed consent. People really, before they join these studies, need to have a very extensive informed consent process. I didn't point it out, but on our slide for our clinical study, you'll see that we have up to a 52-week screening period. So there's ample opportunity to go through, very, very extensive education, informed consent. So anyway, I guess that's sort of both of your questions all wrapped into one. But the most important and promising part of this is to eventually increase the supply of transplantable organs for humans that need them.
Dr. Curtis?
I think the biggest challenge in front of us is really, one is time, right? I mean, so to get data out to a year, it takes a year. To get to 2 years takes 2 years, right? So, and as Dr. Peterson mentioned, 12-week sentinel periods between subjects. It takes a while to get through those enrollments, right? And what we've learned from the first few patients, it's the post-transplant care is everything. The surgeries have gone pretty smoothly, right? The transplant itself looks a lot like an allo. And if you look at how quickly all 3 patients' transplants went, and I always ask the surgeons, does this feel like allo to you? They're like, yeah, if we didn't know this was a pig kidney, it didn't really look any different. But just like in the early days of allo 40 years ago, it was like, how do we manage these patients post-transplant? And right now, as Dr. Peterson mentioned, we're super cautious, right? Any slight subtle bump in creatinine, it's a full-on intervention, right? And actually, one of the charge nurses mentioned during Mr. Slayman's care, they said, during allo, we don't do any of this, right? All the stuff that we're doing, because we just don't know what we're doing yet. But every patient that gets out further, like, we'll have our first patients at 9 months, knock wood, hopefully soon, and we'll learn something new. And our goal is by the end of the first 6 patients that we have a protocol that we feel pretty good about as far as managing post-transplant care. But just like in the world of allo, it took a few years, right, to figure out how to manage patients, what patients can tolerate, what leads to good outcomes. And I think, even 3 patients in, that's kind of where we are now, is what does the post-transplant care actually look like? And the beauty of being, here now is we have 40 years of allo experience. We have a whole armamentarium of immunosuppression approaches and drugs that we can use. The question is really, which ones do you use? How do you use them? And what's the right balance for patients? So I think we're already there, 3 patients in, of how do you, manage that post-transplant care most effectively.
It's wonderful. And Dr. Gordon, bring us home.
Yes. Okay. So, I agree with many of the comments that my panelists have mentioned. I would like to emphasize again the point of these clinical trials being safe. I mean that, and that's really key. There's been in the world of ethics, some people have written how in order for research to be scientific, it has to be ethically sound. So I really want to emphasize the importance of ensuring that throughout the whole study, the study design, informed consent, and monitoring, and so on, that it's ethically sound in the whole process. And one thing to also point out that we need to be sure to do is ensure that any of these trials are engage patients in the process for weighing in and providing feedback on what's working and what's not working in the overarching study. So I'm hoping to bring that back to the lovely quotations posted at the beginning of this day. And I truly believe that the patient's voice is really key to making this a fruitful exercise overall. Thank you.
Thank you. And thank you, Dr. Gordon, Dr. Curtis, Dr. Peterson, for sharing your expertise and passion for advancing kidney care with us today. Your work is providing hope to patients and families around the world. And we're grateful for your commitment and for your vision you bring to this important field.